I'm Karen Hayes, Product Director at Icon PLC. Our company works with big data and advanced analytics for clinical trials, as well as for real-world evidence studies. I am responsible for predictive analytics products and services, and previously I have worked directly with our clients, developing applications for drug abuse and addiction, as well as communicable diseases. And my colleague, Dr. Mehdi Nekouei, is a data science leader. He's a data science manager working with predictive and prescriptive machine learning products and services. Mehdi also has a PhD in engineering from Texas Tech University. And today we'll be talking about leveraging advanced analytics to really understand how the COVID-19 pandemic has impacted substance abuse disorders. Next slide, Mehdi. So a little bit background. I think all of us are familiar with the continuum of drug use and dependence, going from use to abuse to dependence. And as we all know, drug abuse is a tremendously huge problem in the United States. In 2019, if you take a look at patients who were just using and abusing alcohol, over 25% of the US population used alcohol in some way, of which 66 million patients were binge drinkers and 40 million patients, shifting over to other medications, used some type of illicit drug. And of those patients, about 20 million of those patients, or about 8% of the US population, met criteria for a substance abuse disorder. Now, keeping in mind that all of those patients didn't actually go into treatment, but they definitely met the criteria. Now, if we go down that continuum, one thing to consider is that during the pandemic, drug abuse and use worsened. So in 2019, we had about 71 to 75 million deaths from drug overdose. And during the pandemic, that number increased to 99,000 patients who died of drug overdose. And that was up 30% over the prior year. So if we look at the first year of the pandemic, we had a tremendous increase in drug use and abuse. And taking that one step further, about 5% of the entire US population had thoughts of suicide, which is really quite tragic. And the most unfortunate of all is that about 0.5% of the population actually attempted suicide. So how do we better understand that middle section between 2020 at the beginning of the pandemic and lockdowns through 2021 and actually through 2022? How do we understand a little bit more about this population and what the impact of these social factors were on the mental and physical health of patients who were suffering from drug abuse? So if we consider the stress from the lockdowns, all of the economic impacts of patients losing their jobs or being underemployed due to, restaurants and businesses closing or at least shutting down for some period of time. And of course, probably the worst is social isolation and the decreased access to treatment because COVID-19 treatment was prioritized. How to really reach those patients who are suffering or were suffering from the pandemic, and in many cases still suffering from drug abuse. So we begin with the patient journey. So we seek to understand some of the key drug abuse trends. We've broken up the time periods to before, during, and post-pandemic periods using a combination of both descriptive and statistical analysis and machine learning. For patient personas, that's the next step is, once we've identified some of these trends, we want to understand what characterizes the patients and what are some of the drivers of drug abuse in these patients. And finally, it's good to analyze data, but really the end point is being able to intervene and reach these patients earlier, or reach these patients when we otherwise might not have been able to? How do we do that? So we'll talk about how we use machine learning and advanced modeling predictive techniques to do that. Next slide. So let's talk a little bit about our methodology. Again, we talked about 3 time periods. So the pre-COVID was July 2019 to June 2020. We did pick a little bit of a later time into early COVID because we really didn't see quite the impacts of COVID yet. So we wanted to make sure that during COVID period, we were seeing the full impact of drug use and abuse, which was then that subsequent year of July 2020 to June 2021, or the subsequent 12-month period. And then post-COVID, we saw the country opening up and medical offices coming back to more routine practices in July 2021 through June 2022. Our base criteria was looking for patients who were diagnosed with substance abuse ICD-10 codes for either alcohol, intravenous drugs, or opioids. So we really wanted to focus on the most serious forms of abuse. We did use other types of abuse as features into our machine learning models and analysis, but wanted to, in some pre-analysis, really look at what were the most serious forms of drug abuse in the United States. And the way we did that was in 3 ways. Understanding the patient journey. So we performed exploratory data visualization, or EDA, exploratory data analysis. And then in order to segment or better understand patient personas, we did clustering analysis using unsupervised learning. So Gaussian mix models here. And then finally, for patient finding or being able to look at how we might intervene for higher risk patients, we use supervised learning techniques, basically machine learning classification models such as XGBoost, random forest, and also logistic regression. Next slide, Mehdi. So let's talk a little bit about the patient journey and some of our findings. So in the pre-pandemic period, again, this is July 2019 to June 2020, we saw that approximately 13% of the diagnosed patients from literature sought care for drug abuse. But interestingly enough, younger patients, who actually represent a much higher proportion of the drug abusing population, these are patients in the age range of 15 to 24, we saw as little as 5% of these patients seeking drug abuse treatment. So it was much the lowest group amongst all of the age ranges to seek care for drug abuse. So this is, I would suggest, a very high-risk population to begin with. Wanted to note also that in our data, we saw that most patients received care in the physician's office or in an outpatient hospital setting. So as we all know, very few patients actually enter rehab. Now, during the early part of the pandemic, again, this is from June 2020 to, or July 2020 to June 2021, we saw the emergence of a new approach to treating patients, telemedicine. This was extremely helpful since a lot of the healthcare practices and hospitals were quite occupied with treating COVID or COVID-related disease. And we actually saw 7% of the treatments for drug abuse were within that telemedicine place of service. Now, what's interesting at the same time is that there is, well, it's great that patients can seek care. There is also much less validation that that patient was a drug abuser. In fact, drug testing declined sharply. So during the pandemic period, it declined 23% compared to the pre-pandemic period. And we did see, so we talked about that age group, the younger age range, 15 to 24, we did see an increase of 12% of HCP visits for that 15 to 24-year-old group. In fact, this was the largest increase that we saw for any of the groups that I'll show you the actual data in just a second. But wanted to note also that while drug abuse visits increased slightly for older patients, relapses also increased during the pandemic period. And then finally, if we go to the post-pandemic period, we see that telemedicine still remained very high. It dropped just slightly to 6%, but I think many patients and physicians liked telemedicine and made it a lot more convenient and accessible to see doctors. Drug testing surprisingly remained lower. It was 22% lower than the pre-pandemic period, suggesting that there were still patients that needed to get tested that really didn't get tested. And probably one of the most concerning factors is that visits to community mental health clinics or federally funded community centers continue to decline. So in the pandemic period, it dropped 16%. And in the post-pandemic period, visits to these facilities dropped 21%. So the significance of this is that these mental health clinics and federally funded community centers provide access to care for patients that are otherwise uninsured, or they represent a portion of the population in the United States that are often unemployed and may suffer from social inequity. And then the last piece of it is, if you again go back to that 15 to 24 age range period, we saw drug abuse visits for those younger patients increase up 17% over the pre-pandemic period. And if you go to the next slide, Mehdi. And Mehdi, if you want to put yourself on mute. All right, so the patients with alcohol or substance abuse increased during the pandemic, but then dropped to below pre-pandemic levels in that post-pandemic period. And I guess what's most significant here is that the drug abuse related office or outpatient visits did increase post-pandemic. And this seems to indicate that there was a delay in treatment. So during the pandemic, there are many people that didn't get treatment, but then pursued treatment following. So with that, I'm going to turn it over to Mehdi, who will talk about a little bit more about the patients who are suffering from drug abuse and how we reach out via machine learning models and patient finding techniques.
Thank you, Karen. So let's first talk about the patient personas. So what we have done here, we have applied several machine learning techniques to understand the characteristics of the patients and build predictive models. First of all, we have seen the different patient journeys during and pre and post COVID. Then we apply machine learning to these populations to figure out what characteristics they have. Here in this slide, we are seeing two bar plots. The bar plot on the left is showing the different variables, different risk factors that are impacting the risk scores for the patients. Blue ones are showing the risk factors that are increasing the chance of getting diagnosed with
Hey, Mehdi, we can't hear you. So just to pick up where Mehdi left off, the chart on the left it shows the key variables that are important in identifying patients pre-pandemic, and then the chart on the right shows post-pandemic. So if the bars are blue, they are indicative of characteristics of patients that are likely to be drug abusers, and if they're in the red, then they indicate patients that are, or they indicate factors that are decreasing the risk of drug abuse. So when you go across these two bar charts, you'll see that there are some factors that are relatively common. One is that these patients are abusers of other drugs. So you see tobacco use and abuse, as well as alcoholic cirrhosis. So significantly progressed cirrhotic disease in these patients indicates alcohol use and dependence. And then of course, cannabis dependence, use and abuse are significant in both. One of the differences is in the earlier time period, we see that some of the factors that influence and actually do remain in the pandemic period are healthy behavior. So these patients seek preventative treatment, such as making sure they get their influenza vaccine in the prior period or the pre-period. And then on the right side, you can see they're getting COVID vaccines, that this is a significant driver. Another interesting factor is that in the pre-period, depression is a slight indicator of infectious disease. And in the post-period, it is a reducer of risk. And we think that it is a reduction of risk in the post-period, primarily because these patients are getting treated and depression is being diagnosed secondarily. Mehdi, we don't hear you yet, but as soon as you come back on, we'd love you to speak. Okay, next slide. So this slide just is pretty unique. Part of what we can get from machine learning models are all of the characteristics of patients. And in these machine learning models, you can see it's not just 3 or 4 characteristics, but it can be anywhere between 50 and 100 different characteristics or features that distinguish those patients that are substance abusers versus not. What's interesting here that we didn't talk about yet is mental health. We see in drug users and abusers, psychoses, anxiety, and depression, as well as treatment, antipsychotics, psychotherapy, as well as behavioral counseling. And also the other piece of this on the positive risk factor side are some of the social risk factors, such as lower education level, homelessness, and again, that younger age. And with that, Mehdi, do you want to go to the next slide? So the next thing we did was we created personas, or essentially used, as we talked about, Gaussian mixed models or clustering techniques to group patients into low risk, medium risk, and high risk groups for drug abuse. And by doing this, the purpose of doing this is to really understand these patients a little bit more so we can recognize them, number one, when we see them as healthcare providers, but also be able to know how to reach out to them. And we can see what distinguishes the low risk group here is we call them health conscious and preventative. So they're seeking preventative care from their doctors, including vaccinations, and their high risk behavior, either sexual addiction or sexually communicable diseases. That rate is very low. Their rate of mental health disorders is relatively low as well. And if we compare this to the medium risk patients, we call this sad dabblers. So these are patients who are using a little bit of other medications, perhaps cannabis. They do have relatively progressed cirrhotic disease, so they tend to be alcoholics. And of course, they have a higher rate of HIV. And then finally, multi-vice seekers. It seems that drug abusers that we identified in our data don't just abuse one type of drug. It's very frequent. In fact, most patients are abusing multiple types of drugs, including that this was not part of our model, but we did observe that amongst opioid IV drugs as well as alcohol, there was multi-abuse going on. And you can see it here in this model, very high rates of cannabis dependence, as well as alcohol and tobacco use. And then very high rates of depression and also low rates, very low rate, almost non-existent COVID vaccine. So a bit of an unexpected finding, but low rates of COVID vaccine. Mehdi, are you back?
Yes, I just got my mic connected. I can talk to the next slide. Sorry for the issues we are facing. So thanks, Karen. So Karen covered the insights about machine learning models. What we are going to do next is to apply predictive modeling and find the risk scores. We talked about the risk scores, but we have not seen them. So what we are doing here, we are applying a model called XGBoost to predict the risk scores. Again, what is a risk score? Risk score is a number between 0 and 100, and the higher this number, the higher the chance of the patient to get diagnosed with substance abuse. So what we want to do here is that to have an early detection of the substance abuse and intervene with those patients that have a higher risk, and to save them from getting diagnosed with substance abuse, to have suicide and other consequences of the substance abuse. So what we are showing here, I want to summarize this, is that if we look at the risk scores or the probabilities about 0.75, which is 75% here, we will get over 97% accuracy, meaning that if we select that population, our predictions will be 97% and more accurate. And if you want to compare that to the random guess, what is a random guess? Random guess is meaning that we are selecting the patients from the base populations randomly. We have about 5 million patients with substance abuse, and the overall population of the patients that we have is around 250 million. So it gives us around 2%. So if we choose the random sample, it will give us 2% accuracy. But if we use this XGBoost model, it gives us 97% accuracy. So what that means is that we need to pick less number of patients to get that coverage with the same amount of patients from the random guess. So these kind of modeling techniques will help us to intervene early in time and find the patients who are at high risk of the substance abuse and do necessary clinical as well as psychological treatments for those patients. With that, I'm going to pass it back to Karen and talk about how can we use these risk scores and patient findings to intervene and treat the patients.
Yes, so one really important technique that some of our clients have used and applied this at the state Medicare or state insurance level, as well as within integrated delivery networks, is to use something called triggers. And what triggers are is we would score the population within this healthcare universe, so at the state level or within this IDN, or a population that's selected. And when we score this population, as Mehdi talked about, that score would go from 0 to 99%. And so the higher the score, the higher risk the patient. So this is where we can identify those patients. And we can not only just identify them, but we can identify them when they become high risk. And we can then deploy multiple methods to communicate with those patients or intervene. So clearly at the point of care, when they're visiting their physician, we can help the patient understand some of their underlying mental health and social issues, or cue the physician to do that. We can also reach out non-traditionally through social media or digital approaches, providing additional information and support. And then also work with the doctor at the time that the diagnosis is taking place to motivate the patient to accept that diagnosis and begin treatment. And then if we see that that patient is, has a break in therapy or maybe has left rehab, we can also cue the physician or trigger the patient to return to rehab and continue their treatment. So this type of cueing technique really can support not only finding the patients, but intervening at the points in time to get those patients treated and remain in treatment. All right, so just to wrap up very quickly, next slide. So I think we are all aware that addiction is a very complex but treatable disease, but that patients really need quick access to care. And so that quick access to care is going to increase the likelihood of sustained recovery and better mental and physical health, as well as financial and social outcomes. However, we did observe that more patients are suffering, and many of them may not have been treated yet or are undertreated, as we saw from some of the evidence in our trends, and also from the personas. Many of those patients have either remained untreated or delayed treatment due to the lockdowns and have progressed significantly to the point where some of the changes in their brain may make it difficult to recognize when they do need treatment. And this may be true in particular in patients who are suffering from healthcare inequity. So populations may be in certain ethnicities or poor areas where education levels lower, or who are facing homelessness. However, the good news is that tremendous data sets, big data, our database has over 300 million USD identified patients. Our database can be used in combination with advanced analytics and modeling techniques to really reach that undertreated, untreated population and provide the interventions that those patients need. And that we can use omni-channel approaches, not just traditional PSAs or wait for the patient to go to the doctor's office, but we can use, digital and other channels to reach those patients sooner and get them into the healthcare settings that they need to get better and improve overall outcomes, but also just the social fabric of our own countries. So with that, thank you very much on behalf of Mehdi and myself.
Thank you, everyone.